Hi guys, Dr. Annie Heaps, family nurse practitioner. We are going to go ahead and jump into our webinar today. Lots of content to cover. I am a family nurse practitioner by trade, specialized really in geriatrics and preventative medicine. Those are my two big loves. If you guys have seen me give a webinar before, you know that I have a lot of soapboxes and a lot of tips and tricks to share. I love our older adult patients and I love preventative medicine. I love the effort that the United States especially is taking to try to work more towards that upstream approach of preventing diseases. I worked in the ER first when I was a nurse, and before I went back to NP school, and I just remember thinking it was kind of exhausting, like not being able to do anything. If a patient comes in after smoking, 2 packs a day for the last 30 years and they have lung cancer, like we can try to treat the lung cancer, but they already have lung cancer. There's nothing I can do about that. And I just thought, oh, I wish someone had intervened earlier 30 years ago and told them the dangers about smoking and followed up every single year to get them to stop smoking or to exercise more, etc., to lead to long-term health. So this is a very important topic because we discuss this every single day with our patients. So annual exams, these are really key times to discuss that, but you don't have to just do it at an annual exam. Every single patient encounter that we have, we want to close any gaps in care, and that means you have to know as an advanced practice nurse, both for your board, because it's highly testable board information, but also just for everyday practice, you need to know these screening guidelines, because how are you going to educate on what you don't know? Couple disclosures to go over first. Nothing fishy here, really, is all I'm telling you guys. If you are joining through Zoom today and you stay for the full hour webinar, you do get 1 continuing education credit. So make sure that you stay for the whole time, and then that gets sent out to the email you signed up for the webinar through. Other disclosures, just we don't really have any financial relationships with any individuals. I'm trying to push anything. This is just evidence-based practice, what I've known from clinical experience and what textbooks and just evidence support. So we can dive right into that. Today, we're going to cover 3 big learning objectives that I want you guys to know and understand by the end of this webinar. First off, we're going to identify risks. We're going to identify risk factors, and then we're going to identify the risk-based screening recommendations. So what are the screening recommendations out there? We're not going to get too in-depth into like vaccines today, but really things like cancer, cardiovascular, women's health. What are the screening recommendations? When do we do them? When do we recommend them? How frequently? And what specifically do we test for? So we need to be able to differentiate between those diagnostic screening mechanisms and then also just surveillance mechanisms. So we'll do that, and then we'll look at the actual recommendations in a case-based scenario aspect with a couple practice questions just to make sure you guys feel board and clinic ready. So that's kind of our big objectives. Now, as we jump into the actual content of our webinar, I want to start us off on Slido. And if this is your first time in an Archer webinar, we use Slido. It is a another feature that we'll kind of jump back and forth between in this webinar. It just makes it really easy for me to interact with you guys because you are joining from Instagram, TikTok, YouTube, Zoom. And so I want to make sure that I don't miss any questions, that you guys are able to all participate on one platform. So best way to join this is going to be to scan this QR code right here with your phone. If you're watching the webinar on your phone and you still want to participate in the Slido, just type in another browser, slido.com, and then when it pops up with this little hashtag, you just have to type in screen, and that will take you to it. So without further ado, I'll give you guys just a few minutes to jump in and join, and we will start with some easy questions. First off, I want to know where you guys are joining from. That is always a really fun question for me because we tend to get a fair amount of people from kind of all over the United States. I usually will have at least 1 or 2 that are joining from outside the United States, whether they're on vacation or studying to take their boards coming in here. Mississippi, California, Wisconsin. We have a range of weather on this. Oh my goodness, an even bigger range of weather. Arizona. That is where my family's from. I think it's like 120 degrees in Mesa, Arizona, where I am from today. Florida, California. Okay, guys, we've got a good little group here. We kind of spread, from south to north and east to west. So I'll give people just a little bit more time to join if they want. But in the meantime, I want to know where you guys are at in your journey so that I know how to really tailor the webinar to you guys. Are you studying for boards, first semester of APRN school? You're already a practicing clinician and you just want a review again about screening guidelines because it is can be a tricky subject. Where are you guys at? Graduated, studying for boards, board prep. I mean, we are, a lot of our products are board prep products. So that is good to know that you guys are using us for board prep. I can disclose here now, I feel like when I took my boards, Archer FNP is exactly what I used. It was the only product I used for studying. So I did their entire Q bank. I read all the rationales, the videos that were linked, watched their webinars, the on-demand videos, and I passed first time around. I felt really prepared going into that test. So it's fun to work at a company that you feel like actually cares about our students and puts a really good product out. So I can stand by what we do at Archer. And then one more question. How confident do you feel about screening guidelines right now? Is this a subject that you're like really overwhelming? There's a ton of guidelines. How do I know who to test? Or this is something that you feel pretty comfortable about? Give me the lowdown. Okay, guys, this is pretty good. I'm happy. If we're sitting at a 6, I'm happy with that. Of course, I'm always happy if we're sitting lower than that too. I promise you guys are going to feel better about it at the end of the webinar. Every time I've given this webinar, we have significantly increased the confidence guidelines, which is why I always ask this question. I want to know, do you guys feel like this was effective, like you learned and you felt better by the end of the webinar with what you were testing? So good to know there. And, oh, don't answer that question yet. We're not ready. Okay, now we can get into the actual meat and potatoes of the webinar today. Where do we find guidelines and how do we know they're evidence-based? Because those are going to be really the two big things you need to know as an advanced practice nurse about screening guidelines is how do you find them? And how do you know that they are evidence-based? Because we are evidence-based practitioners. That's a big thing. A lot of us, we say advanced practice, nurses, APRNs, NPs. The term I like to use, the title that's my most favorite is evidence-based practitioners. That means every treatment guideline I employ for my patients is evidence-based. It has research supporting it saying, yes, this is what right now we know is the best thing to do, the best thing to screen for. I would say the most trustworthy place to start, especially if you're practicing in the United States, is the U.S. Preventive Services Task Force, or USPSTF, or sometimes you'll just hear it called the task force. What they state their goal is they say they work to improve the health of people nationwide by making evidence-based recommendations on the most effective ways to prevent disease and then also prolong life. So we're going to mainly focus on their A and B guidelines. They kind of grade everything A, B, C, D, or I, meaning we just don't have any evidence yet to say either way, so we don't know what to say, which I think some people find irritating, but I would say I appreciate that they're just upfront about it. They say there's more testing needed on this. We need more research done to tell you yes or no. Spend your money on this. Don't spend your money on this. It's worth the risk. It's worth the time, etc. So I'm totally okay with the screening recommendation of I. It just means, there's a spot for research. They look at over 80 different conditions and diseases, and they will tell you this A and B's kind of are best. That's when we know, like, if something's graded A or B, we know they're saying, yeah, this is pretty important that you do this. Like, we know that this either catches disease early, it prevents disease, it helps prolong life, it increases quality of life, etc. So you want to make sure you're doing those. We're going to then talk on we'll talk on some other screening guideline places like the ADA for diabetes, ACOG for gynecology. So there's some other people that put recommendations out, but this is the most comprehensive, especially in the US, is the USPSTF. And so I would start there. My little tip and trick for you guys here would be to download the app. They have a free app, and that free app, I think, does a really good job at making it usable for in the clinic. With my green screen on, it's kind of hard for me to show you guys, but I have a medical folder that I use for work. I don't know if you guys can see that. And right here, this is the US Preventative Task Force app that they have. They have it both for Apple and for Android. It's free. And when you open it up, you can search for certain recommendations. So you can just search for like cancer or lung cancer, pap smears, etc. But the way I like to use this the most is when I go in to see a patient, there's a spot for age, weight, height, sex, if they're pregnant or not, if they've ever used tobacco in their whole life, and if they're sexually active. So you'll put in all of those little features of your patient, click search, and it will tell you all the recommendations that apply specifically for your patient. Because remember, I said they look over 80 conditions and diseases, so it can get really confusing about what does apply to your patient and what doesn't. So I would say definitely recommend you download that app and use it during your clinical rotations, use it during your clinic, use it for board prep, etc., to make sure you understand what applies to your specific patient. Moving on, let's look first at type of prevention. I think it's important that you understand the 3 different types of prevention so that you know how to categorize them as we're looking at the screening guidelines. This is also just, I know you learned this in nursing school, but it can be tricky. Some of them can feel like, okay, this sounds like it's both primary and secondary, or secondary and tertiary, and you can get mixed up. And this is a highly board testable question. They like to ask questions like they'll give you a prevention method and ask if it's primary, secondary, or tertiary. So know these. My little tip and trick is that if I say the word primary prevention, I want you guys to think of the first little P, primary, for prevent. So some educational topics that would be primary prevention strategies, things like vaccinating an infant, telling a young child they need to wear a helmet, reminding young adults to wear their seatbelt. Anything really that is going to prevent something bad from happening is going to be considered primary. So primary, prevent. When you look at secondary, what I want you guys to think is the S in secondary stands for screenings. That's going to be where the USPSTF guidelines come most into play. So throughout the screening guidelines webinar, we're mostly going to be talking about secondary prevention because it's not going to prevent colon cancer by doing colon cancer screening, but it will catch it earlier and hopefully improve the length of life and the quality of life by giving you more treatment modalities. So really important that you understand that the secondary is screening. And remember, when we're utilizing primary or secondary screening, there's no sign or symptom at this point. So we don't know that they have a condition. We don't know that they have colon cancer because then why are you doing colonoscopy? We don't know that they have measles or mumps or whatever. We are trying to prevent or catch early. So no signs or symptoms of the condition. That's if you ever encounter a question where they discuss an event that has already happened, that's going to help you throw out primary and secondary as options, and you're going to move straight into tertiary. And when we talk about tertiary, I want you to try to mitigate any further damage. That is the purpose of tertiary. So I like to use tertiary, T for throwback. It's a throwback. We want to try to help them get back to their baseline after an event has occurred. So they didn't wear their helmet, which we try to tell them during primary prevention. And now in tertiary prevention, it's going to be maybe physical therapy after a bike accident to help get them back mobility. You know, if they were paralyzed in a bike accident, that's going to be more on the tertiary. Other examples, any medications that help a client lower their A1C. If they've already been diagnosed with diabetes, that's going to be tertiary. Where they're screening for diabetes, like we know we screen women during pregnancy for gestational diabetes, secondary screening. If we already know they have diabetes, we're giving them meds, we're giving them physical therapy, antiplatelet medications, etc. That's going to be tertiary. Okay, now that we kind of understand those main types of prevention, let's dive in. And remember, I said we're going to focus mostly on secondary today, so keep that in mind. Little pop quiz time. We'll hop back over onto that Slido. And what I want you guys to look at here is what is the #1 cause of cancer that leads to death in the US? So the #1 death causing cancer in the US, what is the right answer? Who knows? I know there's a lot of different types of cancer, and a lot of them are actually kind of on the rise. So that can be kind of a hard, tricky question if you're not exactly sure. Lung, we've got some answers for lung. Let's see. Another lung, bowel cancer. Bowel cancer is a good guess because it is one of the cancers that is on the rise the most in the United States. It is the #1 cause of cancer leading death in men under 50. So kind of a trick question there because they start to really pull out the populations. But you guys are right. Overall, the #1 death causing cancer in the US is lung cancer. It remains up there. And therefore, it really is imperative that we're screening because they're the most vulnerable population. We have so much evidence that smoking is so addictive and so damaging to lungs. Even secondhand smoke, we know, is so damaging to the lungs, causes cancer, causes decreased lung capacity, lung elasticity. So we really want to not only be doing lung cancer screening, but also remember it is a grade A recommendation that at every single visit for a patient that smokes, we ask them, have you thought about quitting? You know, there's a lot of medications out there that can help you quit. There's a lot of programs that can help you quit. What's stopping you from quitting? Do you want to quit? We always ask those questions for every single patient that comes in that is using tobacco. But remember, we're talking about secondary screenings. That would be primary prevention, is that education ahead of time to get them to stop smoking. For secondary screening, the big thing that we want to do here is a low dose CT scan. And the people that we screen, there's a couple caveats to who we screen, because remember, a low dose CT is a bunch of x-rays that are put together to give us a CT of that area, which means innately there is a risk to having a low dose CT because of the amount of radiation that comes with a CT scan. So therefore, when they're looking at evidence, what they're trying to say is, if we catch the lung cancer, are we going to be able to treat it? And is doing the low dose CT going to catch the lung cancer faster than we would otherwise? And they have said, yes, this is a grade A recommendation, but they put a couple caveats there. We only screen individuals between 50 and 80. 50 because usually they won't get lung cancer younger than that. And we stop at 80 because usually after the age of 80, the lung cancer is going to be what kills them at some point, and no treatment modality is going to really improve quality of life to the point that it's worth the CTs. So that's why we go 50 to 80. And two more caveats. They need to have a 20-year pack history, and they need to either currently smoke or have quit smoking in the last 15 years. So remember, we're looking at age 50 to 80, pack history needs to have 20-year lifetime pack history, and then they're either currently smoke or they quit in the last 15 years. And how do we calculate a pack history? Because remember, pack history isn't just how many years you've been smoking. It's how many years you've been smoking multiplied by the number of packs per day they smoked. That's because we know that someone who smokes 5 packs a day is at higher risk for lung cancer than someone who smokes 1 pack a day. It's just more cigarettes. So just multiply packs they smoke per day times the years. So for example, if you smoked 2 packs per day for 5 years, your lifetime pack history would be 10 years. 5 packs times, I don't even remember how many years I gave you guys, but if I said 2, then the answer was 10. I lost my brain. So smoking 5 packs per day for 2 years equals 10-year pack history. Just like if you flip it around, you smoke 2 packs per day times 5 years, 10-year pack history. The other thing I want to note in here that trips students up is this word lifetime. Do not mess up the lifetime. It doesn't need to be 20 consecutive pack history years. They can add it up. So let's say they smoked from 15 to 16, 5 packs that 1 year every day. So they already have 5-year pack history there. They stop smoking for a while, pick it back up in their 20s because they have a bunch of kids, they're stressed. They stop, pick it back up in their 30s because they lost their job and they're stressed and it's a coping mechanism. You add up all those years to get to 20. So don't get tripped up on that. And then they quit smoking within 15 years or they currently smoke. So remember that. And I said we do a low dose CT. I already talked about that. That's kind of everything we do for lung cancer. Remember, this is secondary because if they get the screening and they have cancer, all it's going to tell us is, yes, they have cancer and how far along is it. Then we'll have to do further treatment. The thing is, in addition to getting lung cancer in smokers, smokers are also at really high risk for one other important thing, and that is a AAA, which is an abdominal aortic aneurysm. Those are super dangerous. That's going to be that. Remember the symptoms? It's like they feel like they got stabbed in the back, just this tearing sensation in the abdomen, where the abdominal aorta, one of our biggest blood vessels in our bodies, just absolutely tears and they bleed out very quickly. So of course, that means that's something we want to prevent or catch. And we know that smoking increases the risk of a AAA. So the only other thing we do with smokers here that they recommend is that men, and it's only men, it's not women. So remember this right here. We don't screen women regardless of their smoking history. We offer them a one-time abdominal ultrasound between the ages of 65 to 75 if they have ever smoked. So this isn't a 20-year lifetime pack history. If they had 1 cigarette when they were 15 years old, between the ages of 65 and 70, they qualify for a one-time ultrasound of their abdominal aortic. Does that make sense? Abdominal aorta. So that's kind of the one other screening thing that I wanted to put in there for smoking, because it's really important you remember men only ages 65 to 75. If they have smoked ever in their life, they get a one-time ultrasound. And I keep saying one time because that is different. Remember, this low dose CT we do every single year. That's how, since we know it's the #1 cause of death, cancer causing death in the United States, we know that it's something that we want to keep screening rather than something we do one time. So ultrasound is one time for the AAA. Lung cancer CTs, that's every single year, as long as they fit in those 3 requirements. So as soon as they age out or they have quit smoking and it's now been 16 years, they no longer really qualify for that low dose CT. Moving on to cervical cancer screening. Well, this is a female reproductive one, and I've got another pop quiz for you guys. I want to know if you know the highest risk strains of HPV, because we have learned now in science that not all HPV is the same. Some HPV doesn't really cause cancer, and others are highly likely to cause cancer. So what are those high risk strains, and how do we prevent them? Give you guys just a second to answer that one. '16 and 18. 16, 18 vaccination. Great job, guys. Vaccine starting, yep, 16. Good job, guys. You have totally got it. 100%. With cervical cancer screening, we know that HPV is the #1 cause of cervical cancer, and specifically, even getting more specific there, HPV strains 16 and 18. Those are responsible for most HPV related cancers. And the way I remember that it's 16 through and 18 in my head is I just think 16 through 18, those are your high school years where people start to become sexually active. And I'm not saying that's the average age. I'm not saying that's when, most people become sexually active. In my brain, that's just what I think. You're like a teenager, you can drive now, it's your last years before you go off to college, and we know that unprotected sex can cause HPV, which then can cause cervical cancer. So that's just how in my brain I remember 16 and 18 are the high risk ones. 6 and 11, those are two other important strains. They just cause genital warts. Which I know I say just cause genital warts. Does anyone want genital warts? No, but it isn't cervical cancer. So vaccine's going to be really good for that. But of course, we definitely want to prevent cervical cancer first off. And that vaccine, we have Gardasil, which is the brand name of the HPV vaccine, helps prevent HPV 16 and HPV 18, which are those two high risk types. And that's been approved now up to age 45. It used to be only approved, I think, up to age 25, because then we said after that age, you've already got it, nothing we can do about it. New research is showing that getting that vaccine, really even up to age 45, can dramatically reduce the risk of cervical cancers caused by HPV. So make sure that that is the education you're giving to your patient. It's one of those vaccines that's newer. And I say newer, it's been around for a while, but every kid wasn't getting that. Like my parents weren't really getting that when they were 11 years old. And so a lot of times that feels weird to patients or parents, and they think, oh, my kid's not sexually active, it's not a big deal, my kid doesn't need Gardasil. And so that is always something I try to educate on, is that it is very good for prevention. It can prevent cervical cancer. It's just a vaccine, just like every other vaccine. There's a ton of evidence and research that supports it, and it is very safe. So good to know about that as far as primary prevention goes. Now we're saying, it's maybe too late for primary prevention, or maybe they still got HPV 16 or 18. What do we do now? What's our secondary screening? And that is what we call a pap smear. And that's going to be decided who you give a pap smear on based off those cervical cancer screening guidelines. It is what a pap smear does is it's a screening test, and it detects abnormal cervical cells, and they have recently changed. So make sure that you're up to date on your screening guidelines. Just in the last couple years, ACOG, or American College of Obstetricians and Gynecologists, they are the ones that most people follow, along with the CDC and the USPSTF, and they've kind of all conglomerated together and said, excuse me, this is what is best. Do this. This is our best recommendation. This is what you guys should be following. So it has made it nice and easy for us. And what they have decided is that all pap smear screening should start at age 21, regardless of sexual activity. And that means on both sides. So let's say you're 21 or 22 years old and you're still not sexually active and never have been, you still should be getting a pap smear. On the other side, let's say it's a 16-year-old. She is really sexually active. She's had multiple partners. She's had multiple cases of chlamydia, gonorrhea. We still do not pap smear her. We do not test her until she hits age 21. And that feels weird to me, because we know that risk of cervical cancer, if you're not sexually active, is pretty low, and risk of cervical cancer, if you are sexually active, is a lot higher. But they've just decided that the risk that it's dangerous at that age, or that you actually get it at age 16 or 18, etc., is just so low, it's not worth the pain and cost of testing. So remember, you wait until age 21 and you start at age 21, whether or not they're sexually active. So don't forget that age thing. At age 21, you're going to get it you're going to get it every 3 years. So you get that pap smear. 3 years later, they come back in and get that pap smear. That changes at age 30. So you only do that for 9 years, from 21 to 29. And then once you hit the big old 30, which I think is a big birthday for a lot. My sister just turned 30 and felt kind of like a doomsday birthday for her, I think. She's like, I'm in my 30s now. So once they hit that 30, we switch, and they can still keep doing it every 3 years if they want, or now they have the option to co-test with high risk HPV every 5 years. And so when I turn 30, I shall be switching to every 5 years. I do not like getting a pap smear. I mean, it's not the most painful thing in the world, but it certainly is not comfortable. And so I would rather do it every 5 years rather than every 3 years. So know that from 30 to 65, they can have the option of doing it every 5 years. And then after 65, if they have had normal screenings in the past 10 years, and or they've had or an individual of any age has had a total hysterectomy, which removed the cervix as well as the uterus, that's when we're going to decide we can stop screening. So 65, after the age of 65, no more screening done, or at any age after they have that total hysterectomy. You need to make sure that you clarify the type of hysterectomy with your patient, because some hysterectomies leave the cervix intact. And if they still have the cervix intact, then we still need to be screening. So make sure that we are still checking the pap smear if that cervix is intact. One final thing to consider with cervical cancer screening is that if the patient has a history of any serious precancerous condition, we need to continue that pap smear for at least 25 years after that, even if it takes them over the age of 65. So let's say at age 60, their pap smear came back really weird and they had a precancerous condition that we had to remove. We're going to then continue that screening for another 25 years after 60, even though that takes us over the 65 age limit stop. So remember that. History of precancerous condition, continue 25 years after that precancerous condition is identified. Moving on to breast cancer screening. Do you know what age we recommend to discontinue mammograms? I know we've kind of looked a few at when we start, but you guys know when we stop. When do we say, hey, you know what? If you want to stop, you do not need to go get a mammogram anymore? '74, '75, '75, '79, '70. You know what? We're all in the 70s. That's pretty good, guys. And you guys are 100% right. 75 is when we say, hey, you don't have to get mammograms anymore. And I word that very specifically because it's a conversation between your patient and you. We don't just say, hey, you can never get a mammogram again. I have a lot of patients over the age of 75 that want to keep getting their mammogram every 1 to 2 years because they're very high risk, because their family members had breast cancer, because they had a history of breast cancer, etc. So we stop at that age, not because people don't get breast cancer. It's like you turn 75 and breast cancer just is like, yeah, they're too old for me. I don't want to go get them. But it's do more. It's like, just like with the abdominal aortic, along with the CT, it's a quality of life thing. Are they going to get treatments at that age? Are they going to live long enough that it's worth the treatments? That's all stuff we take into account. And that's kind of why we've said 75 plus, we can discontinue. And there's several sets of guidelines that have been published, all by reliable sources. And so first we're going to look at USPSTF guidelines and then ACOG. These are kind of the two big ones. What I wanted to know is that USPSTF and the CDC did change. It just got updated last year in 2024. So make sure you know that this is the most used one. This breast cancer screening guidelines over here. And what we do is we start now at age 40. So regardless of risk, start at age 40 and they get a mammogram every 2 years unless the radiologist says otherwise. And remember, the radiologist is going to give you the mammogram report and it's going to say, you know, a redo recommended in 6 months, a redo recommended in a year because of fibrous dense tissue, or, you know, continue with regular screening intervals every 2 years. So make sure you're reading that report when you're actually in clinic. As far as boards go, know that it's every 2 years. And then once again, once they hit 75, that's when we have that conversation to discontinue. So important to understand that. One thing to note with this USPSTF and the ACOG is that we offer it at 40, starting 40, and then every 1 to 2 years, depending on their results. But that does not mean that we don't offer it earlier. For certain individuals that we know carry the BRCA gene, certain individuals that we know mom had breast cancer and died at a young age, that's when we're going to start earlier screening. The recommendation right now, as far as I know, is that we start 10 years before the youngest member in their family was diagnosed. So let's say mom died of breast cancer and mom was diagnosed at 45 years old. That means we would then start giving mammograms to her daughter at age 35. That's 10 years before mom was diagnosed. This slide moves on to the American Cancer Society and the National Comprehensive Cancer Network. As you can see here, the National Comprehensive Network is the most aggressive by far. They think we should be starting mammograms at about age 25 to 39, and they should be getting them every 1 to 3 years. So they are the most aggressive, but just know that the USPSTF and ACOG are kind of the guidelines that are most often followed and covered by insurance at this point. So know those. Moving on, we're going to jump on colon cancer screening here in just a second, but I wanted to give you guys a quick break to tell you about our products because I know some of you guys are new to our webinars. Maybe you don't already own an Archer product and you want to know a little bit more about what we do other than free webinars. Big things we have here that I want to touch on for you guys are our question bank and our on-demand videos. And we have a really robust Q bank. Like I said, that is exactly what I studied for my board prep. They have over 1,600 questions, and these are really in-depth questions, guys. They're not just yes or no, do you remember this? These are application and analytical questions that are going to be very similar to what you're going to see on your boards. And in addition to that, they'll give you a readiness predictor. So after you take a bunch of these tests and you've kind of answered questions, when you take these practice tests, they will tell you if you are high likelihood to pass, if you are at risk to not pass, or if you need to keep studying. So that was really useful for me. Once I got 4 readiness assessments that said I was very high in a row, that's when I knew, yeah, I'm ready. I've got this. I know this information. I'm still totally nervous, could pee my pants. I'm super anxious about it. Heart rate's 150, but I know the information. I'm going to take this test and I'm going to pass it. And sometimes just having that readiness exam that it's like, you know what, this is a computer that understands the statistics here. It just made me feel better and I felt so much more prepared because of that. We also have a bunch of on-demand videos, over 16 hours of content, and we've really made them bite-sized for you guys. Everything's topic tagged, so you can just search a topic in your dashboard. This is what you want to watch a video on, and it will pull up that couple-minute video for you. I know that attention spans, mine included, are just in the toilet, so we want to make things as easy as possible for you guys. So make sure that you are signing up just even to get access to those things. The one other thing I'm going to touch on is something newer, and it's our clinical skills. We rented out a simulation lab, full hospital setting, professional videographers, and we made you guys videos on the clinical skills that are hard and easily messed up. I can give webinars all day long and try to explain Murphy's sign and try to explain the valgus maneuver, etc. It's really hard to try to demonstrate, okay, here's my leg, guys, and you're going to move your knee this direction, etc. It's just easier to see done on a patient in a clinical setting. And so we made sure that we got you guys a really robust clinical skills. There's over 200 clinical skills that we filmed during that session. Things like suturing. The suturing video I watched in NP school, guys, no joke, was filmed in like 1970, and they're using the same video, which must mean that that surgeon had a really good stitch. I will say it was a beautiful suture, but the video quality was so terrible. Its narration was just off. I had a really hard time learning how to suture watching that video. So we made sure to film all new clinical skills for you guys to make it really easy to know how to do these skills, whether or not you're in a hybrid program, you live out of state from your program, or you go into class every single day. It's going to be important regardless. Over here in this corner, I put our socials. We've got an Instagram, Facebook, we have a LinkedIn, we have a TikTok. Join us here. We post content every single day, tips and tricks to remember, videos, cheat sheets to download, etc. So don't miss that out. And then of course, my email right here, because anytime you guys have questions, comments, you need help, I'm your girl to reach out to. Okay, moving on. Like I said, we have made it to colon cancer. And who can tell me what the age is that we start colon cancer screening? When do we start colon cancer screening? That is what I need to know. Let's see, we've got 35, 40, 50. Someone want to say 45? There we go. We've got 5-minute increments all the way up to 40. And I mean, all the way up to 50. Oh, we've got 2 for 45 now. Let's see who was right. Exactly age 45. And I will say, guys, this is a little bit of a tricky question because there are so many different guidelines. But if you're trying to pick a number to memorize for boards, age 45. It used to be 50 years old. So I know someone said 50. This is a previous, that was a previous age, and we've now changed that because colon cancer is so on the rise. It is now the second leading cause of death in men and women. So remember that. It is a huge cause of death. It's on the rise, especially in the United States. They think most likely because of our low fiber diet, we have a highly processed diet in the States right now, and people are not getting enough fiber in their diet. It is causing colon cancer. So make sure that you understand colon cancer screening. This is going to be one of the tricky ones, in my opinion, but one of the ones that is very tested and you need to know. So we start at age 45 now, and earlier based on risk factors, that based on risk factors follows the same thing as breast cancer. So 10 years from the family member that was diagnosed the earliest. So dad gets diagnosed at age 30 with colon cancer. You technically are going to start colonoscopies for yourself then at age 20. So 10 years before family member was diagnosed. Other than that, you start at age 45, and the frequency is going to be determined based off findings and what test you do. So there's 2 main pathways. We've got the colonoscopy, which is where they put you under, they stick the scope up your booty hole, and they look at your sigmoid colon, your anus, etc. That is going to remain the gold standard. So this is going to be the best way. And the nice thing about colonoscopies that I try to tell my patients when they're trying to pick, oh, what do I want to do, is that all the other screening test options, if they come back abnormal, you have to go get a colonoscopy. So for me, I'd rather just get my colonoscopy and be done with it rather than have to mail in a piece of my poop and then find out it was abnormal and then still have to go get a colonoscopy. Now I've both mailed in a piece of poop and had to been scoped. So for me, it's just like one and done. Also, that if you have a normal finding, it's going to be every 10 years. So it's really not that frequently. It's not so bad. My dad threw a major hissy fit about having to go get his colon cancer screening. And you'd think, Annie, you have your doctorate. You're an advanced practice nurse. Doesn't your dad listen to what you say? No. He's just as bad as my patients sometimes, and it is just as hard to get him to do the screenings that I want him to do. And I just kept talking to him every single time I came home. I was like, Dad, time for you to get your colonoscopy. Here are statistics about colon cancer. Here's what we can do. It's really not that bad. And finally, after my mom turned 45 and got hers, he was like, okay, she said it wasn't that bad. So he went a year or two later after that, and got his, and guess what? They found a precancerous polyp and they cut it out. And I was really glad that he went, and he was really good that he went, because with colon cancer, early detection is key. Colon cancer is very deadly if it is caught at a late stage. The earlier we catch it, the better quality of life's going to be, the better longevity is going to be. So that's colonoscopy. Remember, usually redone every 10 years. If they find a lot of polyps, it will be done every 5 years. On the flip side, the other option is at-home screening kits. Like if you've ever heard of a FIT test that detects blood in the stool, is mostly what they're looking for. Couple caveats to doing a FIT test. There are some things that they have to qualify to get that test. Otherwise, they have to get a colonoscopy. And that means they have to be low risk, meaning like no family history, they're not smokers, etc. And they have to have a history of no polyps or a family history or personal history of colon cancer. So if they're high risk, they have a family history or personal history of colon cancer, or they've ever found polyps on a colonoscopy, they have to get a colonoscopy. They can't do the FIT test. That's not really an option for them. There are several different tools, and they are fairly cheap, but you do have to do them about 1 to every 3 years. And so I don't know. They have to be done more frequently. And then, like I said, if the result is positive, meaning they found blood in the stool, they need to get referred out to GI for further testing and for a colonoscopy. So I always say colonoscopy is gold standard. Other tests are options, though, if patients do not want to be put under or to have, an actual procedure done. Our final mention today is going to be bone density screening guidelines. And bone density, what it is detecting is it is looking for osteoporosis, osteopenia, and just really seeing what the risk is of a pathological fracture. And what osteoporosis and osteopenia is it is this decrease density of the bone matrix. So we know that our bones are made up they're a little bit porous because we want them to be light. Remember, if our bones were completely dense, and highly dense, we wouldn't really be able to move. It'd be like walking in high gravity where your bones are so heavy, it would just add on so much extra weight to our body. And so in that regard, our body finds this really good homeostasis point of bones that don't break so easy because they're not fragile, but also bones that aren't so dense that it's too heavy to use. And so our body really wants to be in this perfect sweet spot of bone density. We know though that as we get older, two things happen. Osteoblast activity increases, which means we lose bone, and then osteoclast decreases. So we stop well, really what happens in all reality is that we stop making new bone and our body starts eating up the bone that it already has. And that's due to a lot of different things. The cells, estrogen, we know that when estrogen decreases, that increases bone resorption, meaning higher levels of calcium in the blood and lower levels of calcium in the bone, which makes our bones more fragile. But if you just remember those two things, that as we age, we stop making new bone, stop making as much new bone, and we start reabsorbing old bone, you're going to see that you're going to all of a sudden have this imbalanced teeter-totter where bone resorption is happening faster than bone creation. And that's going to lead to less dense bone. It happens to every adult as they get older, but it happens more in women because of that estrogen I was talking about. Because of that, we screen women for bone density. Men also can be screened if they have a lot of risk factors, but just like the abdominal aortic ultrasound was for men who smoke, DEXA screening is really a screening recommendation guided towards women. And most women are screened every other year. So every 2 years, we start at age 65, and then we just kind of go until they die or until they decide, hey, even if you tell me that I have severe osteoporosis, I'm not going to do anything about it. Because as soon as my patient tells me that, then there's really no purpose to screen for a DEXA scan. If they already know I have really bad osteoporosis and I've gone through their treatment options and they don't want to treat it, it's just a misuse of resources at that point to keep testing them. So make sure it's someone who wants to treat it if they have osteoporosis, that they are at least 65, and then you're screening about every 1 to 2 years. And what happens is a DEXA scan, it stands for dual energy X-ray absorptiometry, which is DEXA scan, way easier to say. And it screens those postmenopausal women, and it's going to tell you a score about how dense the bones are. That's going to be called your T score. And this is something you guys need to memorize. A T score of less than -1, meaning like -1.5, -1.7, to -2.4, that's going to be what we consider osteopenia. So greater than -1 is normal. So you want, like, if your bone density is -0.5, that is normal bone density. If your bone density is -1.5, you have osteopenia. And then anything -2.5 or greater is going to be considered osteoporosis. The other thing you need to know in addition to T scores is FRAX scores. And FRAX scores take your DEXA scan, they look at everything, and they decide what is the risk of developing a fracture. Normally, they'll do a hip fracture in the next 10 years. So it's a 10-year risk, and anything greater than 3% we consider to be really high risk. So that's when we start saying that, yeah, we should treat it. If there's 20%, or greater of a major osteoporotic fracture, so that'd be something like the femur or the arm, we also consider that to be very high risk and we should treat it. The difference between those two percentages I know can be confusing because you said 3% for the hip we treat and 20% for the other bones. That's just because it's more normal to break an arm than it is to break a hip. Hips are very dense bones, very sturdy. So if anything greater than a 3% risk of breaking your hip, that's when we start to say, oh yeah, that's bad. Especially because we know hips take a long time to heal and they're very important to our quality of life. And also we know based off research, the length of life. People that break their hips actually tend to live shorter lives. So that is really important. You need to remember both of those so that you can decide when you treat a patient. Last thing I want to note about bone density screening for you guys, and I go more in depth about bone density screening in my geriatric webinar. So I do that one about every month. Catch that one if you want more of this in detail about risk factors, what the treatment guidelines are, etc. But just as far as screening goes, one last thing to note is that we screen adults 65 and older, women, but you can always screen younger if there are risk factors. So, for example, if you have a family history of osteoporosis, if you are a smoker, if you went through menopause early. So we know that the average age of menopause in the United States is 51. If you went through menopause at 45, things like, so you had less estrogen throughout your life, that's when we're going to screen younger than 65. My mom isn't even 50 yet, and she's already had a DEXA scan done because they just kind of decided with her risk factors, she went through menopause a little bit early. They said, I said my mom's not even 50 yet. She is 50. She's not 65 yet. They started her DEXA screening at 55. They just said that was the best option for her. Screen her a little bit younger, check in, make sure that she's getting enough calcium and enough vitamin D, and see if there's any other medication she needs to be put on. Her bones are looking great, and she gets screened every 2 years as a follow-up. So I know I said 65 and older, but know that if you ever get a question where they have a lot of risk factors for osteoporosis, you're going to want to start screening at a younger age. So that's kind of it on bone density, guys. That's the major screening recommendations from the USPSTF on really all of those. I know we could go more in depth about lipid screening, diabetes screening, etc. And I do in other webinars. So if you want to hear more about that, join more of our other free webinars. But for now, I want to give you guys just a couple practice questions to see if you can put all of that information, because it was a lot of information, into practice and make sense of it. So we will jump back over to our Slido. Remember, you can go to slido.com and join its screen, or you can scan this QR code. Our first question here is going to be, a 52-year-old woman with no significant medical history presents for a wellness visit. She's never had a colonoscopy, she's asymptomatic, and has no family history of colorectal cancer. These are really important because these are going to be those risk factors that help you decide if she has normal screening recommendations or screening recommendations that are specific to her risk factors. So take those into account. I want to know, what do you guys think is the most appropriate next step? We'll give you guys just a minute or so to put in your answers. Okay, we've got some answers coming in. Order colonoscopy and repeat in 5 years. Schedule a screening colonoscopy every 10 years. Okay, we're kind of split. We're a split group right now. No one thinks to do the blood testing, and no one thinks we should defer screening because she doesn't really have a family history. She has no symptoms. Should we defer? What are people thinking? Okay, looks like C took the lead. Let's jump back over to our webinar. You guys were 100% right. The correct answer is C. We want to make sure that we're screening every 10 years. Screening every 10 years is the preferred method. It may be 5 years. That risk interval may be shortened, but we always put in our order as screening colonoscopy to be repeated in 10 years until we get something back from a GI specialist that says, hey, they had about a bajillion polyps and they need to come back in next year. So remember, we start with that and we screen every 10 years. That's the recommended guideline, and it changes based off risk factors. That fecal blood test is acceptable, but it does need to be done annually, and the colonoscopy is longer protection and is considered the gold standard. So it's not what we recommend as healthcare providers. And then there's never an indication to wait until 60, even if they don't have risk factors. We start at age 45, regardless of risk factors for colon cancer screening. Okay. Moving on to our next question. A 36-year-old woman presents for a routine exam. Pap smear was 3 years ago, showed no abnormalities. She has no history of abnormal results and is in a monogamous relationship. What is our most appropriate next step? Should we repeat the pap smear just by itself for now? Should we defer screening until 40? Should we perform a pap smear with HPV co-testing, or should we repeat the pap smear annually? Who remembers the cervical cancer screening guidelines? Okay. Great job. You guys were 100. Whoops. Oh, I went the wrong direction. Great job. You guys were 100% correct. You want to perform that pap smear with HPV co-testing. That is the test you do every 5 years. It is the preferred method by the USPSTF if it's available. So since she is between that ages of 30 to 65, she is available to get the co-testing with HPV done every 5 years, and that catches more cervical cancer and it's done less frequently. So that is the preferred method. That's what we're going to offer her. And she is due, since She got just a regular PAP 3 years ago. So we want to make sure that we are recommending this test and educating her about it so that she knows what her risk is and what we do to prevent it. Okay, guys, that is everything for the major USPSTF screening guidelines. I want to go back real quick and give you guys, if you can just answer this for me real quick. This helps me just keep track of how confident you guys are feeling based off my webinar. So are you guys feeling better about screening guidelines now? Did I make it more confusing? Where are you guys at? Okay. 9.2, guys, from 6 to 9.2. I'm really happy with that. I'm glad. Sometimes you just need someone to kind of break down the screening guidelines and walk you through it. And like I said, a lot of these are more geriatric guidelines. And so my geriatric webinar goes a lot more in depth about the actual treatments we employ after we do the screening. So if you want more help on that, we have pediatric webinars that look more at preventative medicine, especially vaccines. So those are some good webinars to jump in as well if you want more help with screening guidelines. And now, just last question I have for you guys. What questions do you have for me? Is there anything I can answer about screening guidelines for you? Is there any webinars you want specifically from us? Any products that you're like, please give me this. I'm dying. This is what I need. What can I do for you guys? We are a student-led company, so I want to make sure that if you guys have any questions, you want help, that I'm there to do it for you. When will there be a 3-day live review again? I know that that is a big meeting on the calendar to decide that date. We're trying to pick dates that we know work for the students because we know a lot of you still work full-time or have kids while you're in NP school. So we want to make sure we have a 3-day live review. In the meantime, you can buy with that SurePass combo, it comes with access to the on-demand version. So you can get the full 3-day live recording that you can watch on your own time, middle of the night, whatever is best for you. Okay, good question here with what does the low dose mean in a low dose CT? It just means it is a lower dose of radiation. And that is important because in a low dose CT, the thing you need to know specifically about it is that the amount of ionizing radiation is going to be directly related to the risk of cancer caused by the CT. So it's important that when we're doing a CT, what we want is we want to catch cancer. We don't want to cause additional cancer. So the goal really with a low dose CT is to minimize the radiation exposure. The more ionizing radiation, that's the word that we use, the better the images. But we have found out with lung cancer, specifically in the lungs, since there's so much air, we can actually use a lower amount of radiation and still get a pretty clear images that is going to catch cancer pretty like most of the time. So the whole goal with any test we're doing is we don't want to accidentally diagnose people that don't have cancer, but we also don't want to miss people that do have cancer. So low dose, we've decided in the lungs, that level of ionizing radiation is small enough to not be dangerous, but also high enough to give you a clear image. So I hope that made sense for you. Any other questions from anyone that I can answer while we're on here? If not, I am happy you guys joined today. Thank you for coming. Archer Review loves having these webinars. It's a great way to interact with our students. We all were students at one point. We're all advanced practice nurses at this point. So know that you guys have done it. I know most of you guys in this group had already graduated and are studying for your boards. I just want you guys to not think of it as a hurdle. I'm trying to think of the best way to word this. For me, you guys graduated, you're APRNs. Making it through APRN school, all the tests, the clinical rotations is the hard part. Taking this board, this is just a test to be passed. You guys are all going to pass. I'm not worried about that. You're going to be great practitioners. People are going to be lucky to see you as their patients. So good luck, guys, studying. Go into that test with confidence, knowing you're going to pass. You're going to be a good practitioner, and people are going to be lucky to be treated by you. I'm so happy you guys joined, and I'll see you guys next time.